Hello everyone, I'm Ea Elspil from Danida Fellowship Center. As you might see, I'm standing here at the Danida Fellowship Center's cafe in Copenhagen. We are very delighted to welcome you to this Knowledge in Action talk with the subject of combating a global pandemic. Before we go into the subject, I would really like to encourage you to share your name and the country you're joining from in the chat. Please, if you would also like to share your LinkedIn profile, we can connect afterwards. Also, please feel free to share comments or questions in the chat so that we can do our very best to accommodate them during this session. As you might see, this session is being live streamed on Danida Fellowship Center's Facebook, LinkedIn, and YouTube channels. I would like to introduce you to Professor Flemming Conradsen, who is our expert facilitator for today. He's from University of Copenhagen and also chair of the Consultative Committee for Development Research, who are those who advises the Ministry of Foreign Affairs in Denmark about support to development research. We have invited Flemming to facilitate this talk because he's been very active in the debate about COVID-19. Flemming and the rest of the guest speakers will share their global experiences around COVID-19, and we have asked them to share 2 key lessons on how to combat a future pandemic. Today we would like to welcome several guest speakers. The first one is Ole Tonke, who is the Danish ambassador in Kenya. And then we have Sanyu Kalibala, who is a country manager and communication strategist at Development Media International in Uganda. Then we have Catherine Ampe-Briant, who is a Danida alum and also Municipal Director of Health Services in Ghana. Then we have Talbot Sonda and Happiness Kumburu, who are both PhD fellows at Christian Medical College in Tanzania. So that was all for me. I shall return later. Now the word is yours, Flemming.
Thank you so much, and also a warm welcome from me. It's nice to see such a diverse list of presenters. So I'm looking forward to inputs from national level and from field level. But first, I'll take you through a few global perspectives, lessons learned, and also just background to our national level discussion. So looking at COVID-19 represented by death per million people, obviously, as you can see from this map, there's a huge difference in terms of impact across the globe. We see that large parts of Africa, also parts of Southeast Asia and South Asia, have been less hit as compared with Latin America and Eastern Europe in particular. But also North America and Western Europe have been hard hit. So that's, of course, if we look on the indicator COVID-19 death. If we are looking at what may explain this difference, then there would be a whole range of possible explanations. Obviously, how the public health authorities have responded, how fast the political system were in responding to a lockdown, how well different countries have been in terms of protecting their senior citizens. But probably more than anything else, the difference across the globe is explained by demographic composition of the population. We can see that the population indicated here by proportion of population above the age of 65, we see that the proportion is much smaller in Africa and parts of Asia compared with Europe and North America, for example. So demographic profile are certainly very different and will play a role in explaining the map indicated before looking at COVID-19 death. Also, you could claim that the map I showed on COVID-19 may not be representative in terms of how many people have actually had COVID and been sick from COVID-19, because the testing and the testing capacity are dramatically different across the globe. So we should keep this in the back of our minds when we compare countries and regions. Denmark has one of the highest tests per 1,000 population found throughout the pandemic anywhere in the world, but we also have places in the world where you have to pay to get tested. The access to a testing facility is a long distance, and this also partly explains the difference in COVID-19 because of potential underreporting. It's important not just to focus on COVID-19 and the difficulties, but also the differences across the world. It is equally important to look at the indirect health impacts of the pandemic. We know from epidemics around the world that very often there's a bigger health impact indirect as compared with the direct impact of the disease itself. So looking at the indirect impacts of the pandemic, it could be the wide impact on a whole range of preventive and curative services that have been hampered or reduced during the pandemic. We have here some data from the Global Fund, specifically for countries where the Global Fund invests, and we see there's been a significant reduction in TB-initiated TB treatment. We also see that preventive services aimed at preventing HIV/AIDS infection have been reduced quite significantly in these countries. Also, we see that family planning services, we have a whole range of reports from, this is from the UNFPA, but also from NGOs, being quite alarmed by the reduction in access to family planning services. And there's a documentation from UNFPA indicating that hundreds or even hundreds and thousands of unintended pregnancies have occurred during the pandemic period, simply because access to family planning services has been disrupted. So there's a whole range of indirect health impacts we should keep in mind when we are thinking about lessons learned, thinking about how we have intervened. Of course, there's also been a whole range of additional impacts of the pandemic on educational achievement, on economic and livelihood aspects. So some of the restrictions and some of the indirect impacts of the pandemic has certainly impacted livelihoods greatly. And some of these features, moving away from looking at a map of COVID-19, we can often capture the direct and indirect impacts looking at excess mortality. And we have certainly seen an equally large difference in impacts across the world in terms of excess mortality. We have about 6 countries of the world where we actually have seen no excess mortality from all causes of death during the pandemic, including, for example, Norway, Denmark, New Zealand, and so on. But for most other countries, there has been an excess mortality. Looking, for example, at Russia, there are now close to 950,000 that have died, excess mortality as compared with the 5 years prior to the pandemic. And that's much higher than the reported COVID-19 death. So excess mortality is one of these indicators we can use in the pandemic to measure impact. Just before I turn to the last few slides, I think it's super important today, and of course in general, to discuss lessons learned linked to our global health governance. There's certainly been significant initiatives taken globally to combat the pandemic, but there's also been certain weaknesses in our international collaboration. Some of the international institutions that have been mandated to govern our global health are simply too weak, under-resourced, or there has not been political support to these institutions. That can be shown in, for example, the vaccine. There's been a lot of factors that influences the vaccine uptake, the doses administered across different countries. But first and foremost, we see that Africa, in terms of coverage of fully vaccinated people against COVID-19, are very low. Most places in Africa are single-digit percentages, 3, 4, 5, 8, 9, 10%, which is far less than Europe, North America, many places in Middle East and parts of Asia, where we have above 50%, and many places in Europe close to 85% coverage. So this huge discrepancy has enormous implications, because if you cannot protect your population with a vaccine, you may even be short on personal protective equipment. You have weaknesses in your healthcare services. Taking out vaccines from the equation leaves these populations very vulnerable. COVAX, an initiative globally for the fair distribution of COVID-19 vaccines, was a good initiative, but has not been followed up by sufficient allocation of vaccine doses from rich countries to poor countries. So that's one, in spite of successes in global health governance, this is an example where we fall short. Just finishing off here, I know we'll have representatives on this discussion today from research and educational institutions. And one thing we have learned for sure during this pandemic is we need to up our investment in research. We need to build capacity also across Africa, Asia, and across the world in improving our research capacity, for example, for testing, but also to get research on behavior change, research into public health policies, and certainly we also need to strengthen educational institutions for our healthcare professional, broadly speaking, can be much better equipped to deal with the next epidemic or pandemic, which we are very likely to face in the future. So after these few introductory talks, let us turn to national level and more field level input. And actually, we'll start off with Catherine in Ghana. Over to you. Catherine, you're the Municipal Director of Health Services, and I know you have been deeply involved in the activities, so we are looking forward to listening to you.
Yes, please. Thank you very much. And a very good afternoon to all our audience from all across the world. So, Jacob, you have my presentation. Can you please roll? Yes, so I'm Catherine Ampa-Bryant, and I'm the Municipal Director of Health Service in Commended Negwafo, a municipality in the central region of Ghana. Next, please. So this is how our facility looks like. That is where I work. I go to every morning. Next, please. So this will be the scope of my presentation. We'll look at a brief updates of COVID-19 in Ghana, our key national strategies, what's been the impact, and then how we are trying to go around it with the integration of services, and then some key learnings, at least two. Next, please. So on the 12th of March 2020, we recorded our first case of COVID-19, and we have a total of 130 077 as at 29th October this year. Our recovery rate is around 97.7%. And then 24th of February this year, we had our first shipment of vaccines. And then as a country, we have been able to vaccinate about 4.2% of our population. We still have the vaccination ongoing for first and second dose across the country. Next, please. So as a country, this is our 5 key national strategies. We're looking at stopping the importation of COVID-19 into the country. And so you realize there was a lot of lockdown, both air, land, and sea. And then even the cases that we had, we're looking at testing and tracing and then isolating. Those who were positive for COVID-19 were treated and then managed. And then again, for us to limit the impact on socio-economic life, we also made sure that people went about their normal duty, however, observing the various COVID-19 protocols put in place by the government of Ghana with support from Ghana Health Service. And then also, we also want to boost domestic production of supplies where we don't have to depend on abroad for supplies like face masks, sanitizers, and the rest, but we'll produce them locally also to empower our people. Next, please. So on a whole, when we look at the impact of COVID-19, even though Prof have mentioned some, for us, one of the key impacts was on our service delivery. So immunization activities were not going on. So children due for their various antigens were not able to give them, and the TB activities very much impacted. Outpatient care attendance also very low, and so resulting in financial loss to healthcare providers. And then in our bid to come back very strong after the lockdowns and all that. The public health units with community health nurses are doing a lot of integration of services where we are going out for campaigns, family planning campaigns, immunization mop-up, so that those who were defaulted can all be traced and immunized. TB cases are all being attended to, or they are being looked for. And then also we are also having general OPD screening, and again, we're also having some school health activities, all in a bid to get people who defaulted during the lockdown to be attended to. Next, please. And so for us as a service, one of the key learnings is that we need a public health system that remains committed to developing adequate surveillance programs. We think that our surveillance system will have to be very robust and be able to detect the case as fast as possible, and we get all the necessary information that we need to take the next actions that we need to take. Next, please. And then again, we also think that in this whole period, the majority of the people who really had to work very well or very hard to make sure that our cases do not die as are recorded in other places is the health workers. So we are looking at having a psychosocial support for our health workers in this pandemic, and if there will be any pandemic at all, we'll have those systems in place so that even health workers who were infected with COVID-19 will have that support to prevent the depression, the anxiety, the fatigue, and all those things that come along with ensuring them to have a complete recovery. Next, please. So I would want to use this opportunity to also acknowledge the numerous support we've received from our government of Ghana, our Director General and his team, the Central Regional Director of Health Service and her team, and then again, my own people, DFC, and then all staff of KiA, MHD, and then all stakeholders that have really helped us to fight this pandemic. Thank you very much.
Thank you so much, Catherine. And a few very important points here, including, which is certainly to be appreciated, the catching up efforts, the investment in trying to identify and catch up on, for example, missing immunization among children. That is really to be appreciated, because we know that is one of the long-term potential impacts of this pandemic. Exactly. And of course also really to be appreciated in Ghana, and I'm sure around the world, the mental health and well-being of our healthcare staff. So thank you so much.
Most welcome.
We'll stay tuned and listen, because we have some options for questions later on. We'll turn to Tanzania, where Happiness will guide us into another area. It links to what you just mentioned, Catherine, in terms of importance of surveillance and so on. But over to you, Happiness.
Yeah, thank you very much. My name is Happiness Kumburu. Along with me is my colleague, Tobet Sonda, and we are both researchers from Kilimanjaro Clinical Research Institute, which is part of a referral regional hospital in Kilimanjaro Christian Medical Center, which is located in Kilimanjaro region in northern part of Tanzania. And currently I'm talking from Moshi town. This is a town situated just under the foot of the Mount Kilimanjaro. And here I have a story that would give us an overview of what we have been going through during this pandemic, and also in our previous research activities. Yeah, for the past 7 years, Tobin and I have been working in establishing the diagnostic of infectious diseases using whole genome sequencing. Whole genome sequencing is a comprehensive method for analyzing genomes of organisms, and it provides the highest possible resolution about an organism genome and has the potential to transform infectious disease research. Now, having set this technology in our country, we have been using it in detection of pathogens from the hospital where we are working, but also we have been using in the detection of the outbreaks and nosocomial infections from this setting. Apart from that, we have mainly been using it for detection of antimicrobial resistance in our setup. And during this time, we have been able to contribute a lot of data in the gene banks that shows what we have in our locality. However, During this pandemic, we thought it was the best time to showcase this high throughput technology by detection of this COVID-19 agent. However, things were not as we thought. There are some challenges that made us not to use the facility to its maximum to provide such detailed information regarding the causative of this pandemic. One of them, because in our previous research studies, we have been making our institution as a center, collecting different samples and specimens from different institutions, hospitals, so that we can analyze them here using this high throughput technology that we have set in this institution. However, this time during the pandemic, we were not able to full access samples from different centers or from the national center. And unfortunately, we could not be able to use the whole genome sequencing in detection of COVID-19. And this, it has been like a challenge. Sometimes we don't also get permission on time. And so it delays, because outbreak is something that you have to act immediately. But on our part, we were not able to do so. So having this kind of challenges, my colleague Tobet came up with a different idea of seeing how we can, in future, avoid such kind of challenges, or try to minimize this kind of challenges. And so I'll let my colleague Tobet and introduce what he has, different idea that he had to help us to counteract this kind of challenges.
Thank you very much, Fleming. Thank you very much, Happiness, for giving me this opportunity. So I will quickly take you through our idea on how to roll out whole genome sequencing into other regions so that we can better prepare for the next pandemic. So to us, we thought that preparing for the next pandemic is not negotiable. So if it's not negotiable, we have to come up with strategies that will enable us to capture outbreaks as soon as they happen. So we got funding from the Foreign Ministry of Denmark, and we will implement this project for the next 5 years. So traditionally, we used to getting samples from different parts of the country. Then the samples shipped to KiA for analysis, and then feedback findings to these respective regions. So after encountering several barriers and several hurdles, so we decided to come up with a different idea. This idea was to use a method that is collaborative, involve several government institutions, including the National Institute for Medical Research and in Tanzania mainland, and SUZA in Tanzania island, which is Zanzibar, and several regional referral hospitals. So the idea here is to decentralize the capacities that we have created for 7 years here in Kilimanjaro, and train these regional hospitals on how to use the technology and generate data on time, share data on time, analyze data on time, and share this data with the Ministry of Health for rapid response and actionable responses that will minimize the further spread of the pandemic. So in this project, we will deploy nanopods to these 6 regional hospitals that are strategically located as indicated in the map. We intend and we believe that once these centers are fully functional, we'll be able to identify these outbreaks as early as possible, and thus we will use these as early warning systems for rapid responses. And also we think that once these facilities are fully functional, we will be able to monitor circulating variants and also identify any new introductions or new variants. Like with COVID, we had the variants of interest and also the variants of concern. So with this technology, as Happiness Kumburu has said, it has high resolution power. We are sure that once this setup is fully functional, the government will benefit in a way that when the next pandemic comes, we'll be better prepared. Next, please. So there are several lessons that we have learned from COVID-19, and some of the lessons have made us come up with this idea. One of the lessons is strengthen local capacities at the source, because in these regional hospitals and district hospitals, this is where outbreaks happen. So shipping isolates centrally and analyzing centrally, we thought that this is not applicable and it's not proper, it's not ideal. So we thought decentralizing it and deploying the technology to these hospitals will mean that we strengthen these local capacities, and these referral hospitals will be able to rapidly generate data and perform data integration and share with the Ministry of Health. Also, some of the lessons that we learned and made us come up with this idea is to strengthen regional and international collaborations. Because the pandemic has taught us that working in silos is not an option. Together, if you work together, you are likely to succeed, but working in silos, you are preparing to fail. So we think that through this initiative, we will be able to work collaboratively with these regional hospitals, both in Zanzibar and Tanzania mainland. And also, the pandemic has told us that combating global pandemics needs global commitments and concerted efforts, both politically and economically. We understand our countries have inadequate health systems, so we call upon international agents that we need to collaborate and work together to make sure that when the next pandemic hit, we're better prepared. Thank you very much.
Thank you so much, Tolbert, and thank you so much, Happiness. It was spot on. I mean, it's so important what you bring out, and I'm sure you're right in stating that it requires this international collaboration in terms of exchange of data, exchange of technologies, and just one of your examples, being able to monitor new variants being introduced or the circulation of existing variants. For example, those of concern will not just be of importance for Tanzania, but will be important for the region and the globe. We have, during this pandemic, certainly realized that a much better monitoring of what variants are circulating and their importance from a vaccine protection or clinical manifestation perspective is required. No country can do this alone, and we cannot build walls high enough to keep out these variants. So much appreciated the capacity you are investing in, I'm sure, also from a global perspective. Yeah.
Thank you very much.
Thank you very much, Catherine, Happiness, Tolbert, and Fleming. This was very inspiring, I hope, for you as well. Now we will have a short break, and we shall be back in 5 minutes. Welcome back, everyone. I hope that you are ready to listen to the second part of the session. Now we've learned from researchers and practitioners in Tanzania and Ghana and Denmark as well. We will continue the next session where we will hear from Sanyu Kalibala and Ole Tonga, who is with us from Uganda and Kenya. So Flemming, over to you.
Yes, hope you had a nice short break. Sanyu, we are looking forward to listen to your experiences from a communication behavior change angle. So over to you, please.
Thank you, Professor Fleming, and hello, everybody. I'm very happy to be here. My name is Sanyu Kalibala, and I'm the country manager for DMI, Development Media International, Uganda. I'm sitting here in Kampala. It's rush hour. There's a lot of traffic around me, so please forgive me if you hear cars and hooting. So DMI is a social behavior change communication organization, SBCC organization with headquarters in the UK, but we operate in Africa since 2005, and we run public health campaigns using radio, TV, mobile video to improve lives and improve health and save lives. We work in 15 countries across West Africa and East Africa. And here in Uganda, we run a family planning campaign. Our main partner is the Ministry of Health. So we work with the Ministry of Health. And since March 2020, we've been working very closely with the Ministry of Health to run its COVID-19 campaign. One of the biggest challenges with working with SBCC or behavior change is in Africa is not knowing exactly the impact of your campaigns. So that's what we work very hard to do. We try to scientifically prove which campaigns bring about long-standing behavior change. So our approach is to test, create, and scale. And this is an approach that was also appropriated by the Ministry of Health here. So we test our campaigns with randomized controlled trials. Once we determine that a model campaign is effective, we then scale it to reach millions of people at a time by saturating the airwaves, very similar to an intense marketing media campaign. But SBCC campaigns can't work in isolation, of course. As we saw with this COVID campaign here in Uganda, you need to have also service delivery that's ready. You need to have commodities that are ready and available in conjunction with community interventions and interpersonal communication to really drive the message home. So SBCC campaigns can't work in isolation. They accelerate action, but they just can't, you need those services and you need those commodities. Next slide, please. So in Uganda and across all our areas of our countries of operation in Africa, as soon as the pandemic hit, we started doing big research and got some funds specifically to tackle COVID-19 and identify the barriers. We had, formative research and barriers analysis to see what messages we needed to develop to tackle this. And in Uganda, we worked very closely with the health promotions department and the risk communication pillar, where we developed a campaign with the Ministry of Health to quickly tackle the pandemic from March onwards. Next slide, please. So in Uganda, we just saturated the airwaves on radio and everywhere else. And within a month, 80% of the population within April, 80% of the population was aware of COVID and knew how to prevent it. And it's really difficult to apply a saturation campaign in Uganda because it's a country that speaks over 24 languages. We have over 300 privately owned stations. We also have many community radio stations. But the Ministry of Health really got all stakeholders involved cultural leaders, political leaders, local leaders, the private sector, to really drive on the message, and really got all international partners involved as well. Yes, so now I'm going to present a quick video to give you an idea of the type of campaign we were running. This video went viral when at the onset of the pandemic, because it really explained to people why it was important to lock down and why it was important to social distance. Video, please.
You may have heard of physical distancing. This means keeping at least 2 arms length apart from other people at all times to reduce the spread of coronavirus. But why is it so important? Without physical distancing, each person infected with coronavirus will infect 2 to 3 others. Each of these people go on to infect 2 to 3 more, who each go on to infect another 2 or 3 people, and so on. Within a month, the infection will spread from 1 to 406 people. But if each person halves the number of people they come into close contact with, the number of infections drops dramatically. Each person would only infect 1 or sometimes 2 people, and each of those infected people would only infect 1 or occasionally 2 more. So the disease spreads much more slowly. In a month, the infection would only spread from 1 to 15 people. That's the power of physical distancing. Keep at least 2 arms length distance from as many people as you can to reduce infections and save lives. That way you protect yourself, the people you love, and your country.
This message is brought to you by the Ministry of Health.
Thank you for that. So here you can see a bit the evolution of the pandemic. So we were in lockdown from March up to July, and then we opened and there was an upsurge of cases. And with our prevention campaign, we were able to bring numbers down despite the country no longer being in lockdown. And then in March 2021, we received the first vaccines, and we started systematically a vaccine acceptability campaign. And that's when things started getting a bit complicated here in Uganda. So we received the vaccine. At the same time, in international press, there were a lot of reports of blood clotting of AstraZeneca. We received about a little less than 1 million doses. There was these stories of blood clotting on international news. So there was a lot of resistance for the target populations, especially for healthcare workers. They were very apprehensive about getting vaccinated. And then the Delta variant hit in around March in India, and then it hit Uganda. And by the time it hit, cases, got very high, and mortality cases also rose, and people realized they needed to get vaccinated. So there was a high demand of vaccines, and then all of a sudden, the Serum Institute in India stopped producing and was only producing for domestic use and no longer exporting their vaccines to Uganda. So all of a sudden, we found ourselves with high infection rates, high mortality rates, no more vaccines. We went into a second lockdown. And we went into a lockdown nearly just waiting for, vaccines to come, where everything was sort of blocked with the COVAX initiative. In addition to that, the people who were finally getting vaccinated, it was very difficult to uphold the reputation of AstraZeneca, because the EU and the UK also declared that Covishield, which was the AstraZeneca vaccine distributed in Uganda, was not recognized in their countries. So that made it all the more harder to convince people that AstraZeneca was safe, effective, and could be trusted. Next slide, please. So right now in Uganda, we're a country of 45 million people, and only 5% of the population, less than 5% of the population has been vaccinated. We had the goal at the beginning when we started our vaccine acceptability campaign was to vaccinate half the adult population, 22 million vaccines. That will no longer be possible with the situation with stockage, the international situation with stockage. Right now, we had to reevaluate our goals, and we're going to vaccinate approximately 10% of the adult population, and we'll try to lift all restrictions. Uganda had very long-standing lockdowns that had huge financial repercussions, but also huge social repercussions as well. We had the longest school closure in the world, and we've seen a huge spike in teenage pregnancy. We had to adapt our campaign to not only be a COVID campaign, but also integrate family planning messages in there. And now that we're getting more vaccines, finally, once we started getting more vaccines, we opened up the country a little bit with less restrictions. We have Moderna, Pfizer, but there are many issues with service delivery, in urban areas compared to rural areas. There are issues with the shelf lives of Moderna and Pfizer. So it's been a bit touch and go with the campaign so far. Next slide, please. So the next slide really shows the evolution of vaccine uptake in the country. So the Delta variant hit, and there was, really a huge demand for the vaccines, but stocks just did not follow, unfortunately. So everywhere you see a dip, it indicates where deliveries were not coming into the country. Meanwhile, it was at a time where cases were getting higher and higher. Right now, we are continuing with our vaccine acceptability campaign. It's going well, but we've really had to double up on also interpersonal communication. Uganda is a country that has dealt with many pandemics. They've dealt successfully with the HIV and AIDS pandemic in the 90s. They've dealt with the Ebola pandemic as well. They're used to running intense public health, social behavior change campaigns effectively, but all these different variants and changes that were out of our control really impacted our ongoing campaigns where we really had to constantly play catch up and change our campaigns from an vaccine acceptability campaign to then a prevention campaign, and back and forth like that as we were dealing with stockage issues. Thank you so much for that.
Thank you so much for this very interesting explanation of the response to the pandemic in Uganda. What is really clear is that the globe is connected also when it comes to communication. So public discussion, it could have been Denmark, about AstraZeneca has wide implications globally. If we ban a certain product, then it has impacts in terms of vaccine hesitancy elsewhere in the world. So the connectedness of the globe in terms of communication channels is obviously well illustrated here. Certainly also your point towards the unreliability, not just overall lack of doses, but the unreliability is also here and how it impacts. But actually what comes true to me most clearly is that there's so much creativity in your communication that there's a lot for us to learn in Scandinavia or Europe, or certainly in Denmark. You have been very good at using past experiences and being present locally in eye-to-eye communication in addition to mass media. So super interesting. Thank you so much. We'll return to you. There might be time for a few questions for you also. Our last speaker before we turn to a few summing comments and questions is Ole. Are you with us? You're muted. Ole in a second. Just maybe we'll go back to Ole as soon as he's ready. Maybe just returning for a second to you, Sonia, in terms of supporting the uptake of vaccines. What is it the international community can do? What is the kind of support that we could probably direct towards you, your organization, the government of Uganda? What is required? Obviously, there could be sending more doses, but is it a certain kind, or is it other kinds of assistance possibly the international community could benefit you with?
Yeah, I think definitely there's a need for, capacity regionally and domestically. If there could be a possibility of sort of accelerating capacity for African countries to produce their own vaccines, I think that would be most helpful. I think also, that there's a real will to donate the surplus stockage in Western countries. It seems like a lot of the vaccines that we're receiving have very short shelf life. We are getting piecemeal sort of deliveries of vaccines on the ground. It makes it very, very difficult to be systematic with the vaccine uptake. And all these inconsistencies don't help. So, I think giving capacity, access, empowering African countries to better face these challenges with homegrown solutions, instead of being in a situation where you're dependent upon the West to tackle this pandemic.
Thank you. Yeah, that's something for us to think about also in Denmark and of course throughout Europe and North America and so on, that we do have at the moment, I think it's 240 million COVID-19 vaccines in stock. Some of them we are unlikely to use within the coming month. So maybe there's something there to be discussed also politically here in Denmark. Maybe Ole has a point to make on that particular note in terms of vaccines. You have been involved in receiving vaccines from Denmark and collaborating in Kenya on their uptake. Over to you, Ole.
Yeah, can you hear me now?
Yes, please
Okay.
go ahead.
I hope. Yeah, thank you very much. And sorry for the technical problems. It of course worked when we had the trial just an hour ago, but as it often goes, it doesn't work when it really matters. In any case, just a brief presentation here from Kenya and how Kenya has been hit by COVID so far. We have had 4 very distinct waves of COVID running through Kenya. Each driven by a new variant, and clearly the last wave we have had was driven by the Delta variant. The official stats say that around 250,000 Kenyans have been infected, and we've had around 5,200 deaths from COVID. But of course, these figures are underestimated due to a very low level of testing compared to what we have seen in Europe. On the other hand, if you look at what people have died from during the COVID pandemic, we have actually at the embassy tried to do some statistics, and despite of the 4 waves of COVID in Kenya, the number of people who have died from, for instance, HIV/AIDS complications, other respiratory diseases, other communicable diseases, malaria, and even traffic accidents still exceeds the number of Kenyans who have died by COVID. And some of the reasons that you alluded to in your introduction, Flemming, clearly has come out here in Kenya. Actually, the Minister of Health in Kenya, I've had a meeting with him not so long ago. he pointed at that the increased hygiene in Kenya had actually lowered the other communicable diseases between 1/3 and 50%, which meant that many more Kenyans were saved and didn't get other communicable diseases that they would normally in a normal year have died from. So actually a positive side effect from the increased hygiene in Kenya. What is clear though that the COVID has had very, very negative both social and also economic effects. In terms of social, looking at the statistics for women's rights, we've seen a number of teen pregnancies, violence against women, rape, etc., are at a long time high in Kenya due to the pandemic. In terms of the economic situation, of course, Kenya couldn't afford the wage compensations, etc., that we've seen in the Western world, and those who have been less hit has been the richest part of the population. A medium hit has been the middle class, but those who's been clearly worst hit in Kenya has been the low class, the informal sector of Kenya, who have been felt left out by the government, who has not really been able to take care of that part of the population during the pandemic, where they have lost everything from one day to another and also lost completely their livelihoods from one day to another. In terms of vaccination, a very similar story to what we heard from Uganda. We had a quick uptake in March, where Kenya received around 1 million doses AstraZeneca from India, that was distributed fairly rapidly in Kenya, and with an expectation of 3 to 4 million extra doses before May. They didn't come due to the situation in India, where COVAX had banked on getting all their vaccines from in the beginning, which meant that in June, many of the people who received the first dose couldn't access the second dose of AstraZeneca, and some had to go beyond the 6-week period that was normally there. So when Denmark, we were able to send surplus vaccines to Kenya, we hit at a time where there was nothing more than 5,000 vaccines left in the whole country. So really good and fortunate timing for that. Since our donation of bilateral vaccines, they have been coming through to Kenya on a steady base. And now Kenya has around 9 million doses, where they have administered already 5 million, which leads to a vaccination percentage around 6%. I think in terms of the disease in Kenya, it's also part of the picture that actually 91% of those who have been diagnosed with COVID in Kenya have been asymptomatic. So that's also a clear indicator that it hasn't hit as hard here than in other countries. In terms of the international rhetoric from the Kenyan authorities, I think there's no doubt that the Kenyan government has felt left out, especially in the period when there was no vaccines available at a global level and no COVAX vaccines were coming in. They felt that the international community completely turned their back on Kenya in that situation, and started to talk about we need African solutions, discussing at AU if vaccine production in Africa should be realized, etc., etc. In terms of lessons, I think in terms of the vaccinations and vaccines coming, I think actually COVAX is a right international response to a pandemic, but it has to be administered differently, and there has to be a privileged access to a system like COVAX to the vaccines at a global level. And COVAX definitely also need to source their vaccines from different producers, not only relying on one producer, in this case from India, where there was an export ban, which led to COVAX not delivering for like half a year when it was very urgent. I think the second lesson is that for the next pandemic, we need to think more about the more context-specific solutions and models to combat a pandemic. I think the world didn't know what hit them, and nobody had the answer. So everybody copied each other. Whether you were one of the richest countries in the world or whether you were one of the poorest countries in the world, everybody had the same response. And looking back, I think it's clear for a pandemic like COVID that no one size fits all in terms of response. Thank you so much, Flemming.
Thank you so much, Ole. Super interesting, and it does, your presentation goes back and touches upon all the other points that are mentioned by others this afternoon. Maybe I could take one of your points, Ole, in terms of finding, COVID has been a major issue, and COVAX was designed to counter the pandemic from a global perspective. And I agree with your sourcing, but also how do we make the global community commit more strongly to delivery of vaccine doses over the coming month? Do you see any solution there, or any, from your diplomatic insights, are there any solutions in the making in terms of getting massively more doses arriving into Africa?
I think for the time being, I hope you can hear me now.
Yes.
For the time being, actually in Kenya has sufficient doses. There are a certain amount of vaccine skepticism here, slowly fading though, but still the amount of vaccines that are coming in is fairly adequate for the time being. Kenya doesn't have the capacity to scale up the vaccination in a much higher gear for the time being. So I think we are actually in a good position right now, also since Kenya is experiencing the lowest level of COVID for the time being, ever since the pandemic broke out, actually. I think also it will solve itself, since the surplus of vaccines in the Western world will continue to increase in the coming months. So I think the problem should solve itself within the next half year to a year.
Okay, that may sound like quite some time wait, but maybe just taking your point, Ole, and if Catherine is with us in Ghana, how does it sound to you? Of course, you had a point about self-reliance, investing more in local production, but how does the comments from Ole sound? It's not just about dosage, number of vaccine doses hitting the country, but it's also hesitancy, the capacity of the vaccine program. How does that sound to you? Does that resonate in Ghana?
Yeah, so here in Ghana, thank you very much for the question. So here in Ghana, the vaccination is still ongoing. There has been a lot of engagement with stakeholders. So we are looking at the traditional authorities, the private sector. We are looking at CSOs, various groups, mother support groups and all that, and the opinion leaders we have in the communities, so that they will even be the key people to talk to their people about the vaccine safety. And so if the leaders themselves in the community have been vaccinated and they didn't have any side effects, or even if they had, they were given treatment, they will serve as the voice to talk about the safety of the vaccines. And we think that most often than not, people in our communities listen to their leaders more. And so if they serve as key people talking to them about the safety, then they are able to accept and then come over. So that kind of engagement is helping us a lot here in Ghana. And of course, the first and the second doses are all ongoing. We just have some few vaccine hesitancies here and there, but it's all being sorted out with the engagement with the very key stakeholders that we have in those identified areas that we have those kind of issues.
Thank you. That sounds a little bit similar to Kenya, but maybe a little different from what we heard from Uganda. What do you think, Sanya? Does that sound similar in Uganda as what we have just heard from Ghana and Kenya?
Yeah, it does sound similar. Definitely in Uganda, as in Ghana, we really also did focus on stakeholders and community. Ensuring that community level interventions were just as strong as mainstream as BCC, and also what we had to do was to we even had, we're constantly debunking. That's, our campaign is constantly, that's the main focus right now. We're constantly debunking false information or skewed information from international platforms and then, it's reinterpreted locally. So at Ministry of Health level, we even had to create a committee specifically to systematically debunk, research, monitor international media, local media, and debunk false information, address false information, and just try to change the rhetoric of falsified information.
Thank you. That has been tried also in Europe and of course at the World Health Organization level, and it is a huge task to debunk what is circulating, especially on social media. Thank you so much. Just turning to Tanzania on a slightly different issue. I know Happiness and Tolbert, you have taken a starting point in diagnostics. Would you, and one strategy, of course, if you don't have enough vaccines, it's too expensive to enforce a lockdown. Testing and tracing is what we have seen as a partly successful strategy. In parts of Asia, it has been very successful. In parts of Europe, maybe only so successful. But what do you think can, based on your experience, testing plus the tracing, is that a significant way forward, for example, in Tanzania? One of you?
Happy?
Well, in Tanzania, as we've seen previously, we did not deploy that being as one of the significant measure taking. We didn't have lockdown. We delayed even in testing, but currently we have got the right awareness from our policymakers also. Now we are taking that to being one of the measures that can help in combating this pandemic. Like currently, we have also measures. We are taking measures to make sure that we undergo the vaccination, and at least we have reached the 40% of the vaccine that was delivered in our country has been used. Though we still have that is a very low number compared to the number of the people who are in Tanzania. But we still believe that creating awareness, and at the end of the day, we will have all people understand the importance of vaccination and also taking measures, especially in this pandemic. I'm not sure if we can employ the lockdown really, but we are trying to take measures like social distancing and avoiding unnecessary meetings that can make people can increase the spread of the infection. But due to our economy and all other socioeconomic activities, we have not yet decided or see that lockdown can work for us. But we are aware that we need to practice all other measures that are necessary. Like we are emphasizing on the washing hands, vaccine, and also reducing meetings or that will make people unnecessary. That will make people get contact to the infection so far. Maybe Tobet can add something from there.
Tolbert, do you have additions to make?
Yes, Dr. Happy. No, I don't have a different opinion, but maybe to add a bit of what Happiness has said. Disinformation and misinformation around media platform has played a major role in negatively impacting our community or population awareness. So unfortunately, the power of media platforms has overtaken most of the institutions in Africa. So it became very difficult for the authorities to come up with the correct information or correct messages to the population. So the right way to enhance testing and tracing, it's solely by investing on community engagement, because we have seen so many programs that seriously are investing on community engagement approaches, like the TB test and trace. It has significantly increased the number of new cases and the follow-up. So with COVID-19, I think also concurrently with creating awareness, we can bank on community, investing on community engagement activities. With this approach, we can enhance the uptake of vaccine and testing as well. Deploying without proper awareness in the population may not give the intended outcomes. We need to invest on community engagement activities. We need to invest on population awareness and providing the right information to our population for them to be able to correctly come up for testing and vaccination. Thank you very much.
Thank you so much, Tolbert and Happiness, and thank you to all presenters today. It's quite clear there are so many commonalities across the countries that are represented now. The necessity to be deeply engaged with the community and across a whole range of stakeholders, the need to be very active on media, whether it's debunking false stories or being active across so many platforms in communication, comes through very strongly. The importance of a reliable vaccine supply is also quite clear. And certainly also the importance of catching up. There's been direct and indirect impacts of COVID-19, and what clearly should not happen is that in 2 or 3 or 4 years, we can still feel the significant impact of children not being immunized or girls not having access to family planning and so on. So the catching up is quite clear from what is being communicated across the 4 countries now. And also, I would say, many promising positive notes that have come out from this discussion, from Ole in Kenya pointing at the many prevented hygiene-related infections, the trust in the healthcare services, the need for investment, the initiatives taken. So I would say I would leave this communication actually quite uplifted in terms of the creativity and the response taken across the 4 countries we have now heard from in Africa. At the moment in Europe, we are facing the beginning of a winter that honestly doesn't look terribly promising, especially in the eastern part of Europe. So I'm sure there's a lot we can learn from the initiatives taken in Africa at many different levels. So thank you for listening in, and thank you for your contributions, also chat-wise, and a big word of appreciation to our presenters today. Thank you so much for your time, and thank you for your valuable inputs. Thank you so much. Over to you.
Thank you very much. I would like to also thank Professor Flemming Conradsen and the rest of the guest speakers today, Catherine, Tolbert, Sanyu, and Ole, for brilliantly taking us through this Knowledge in Action talk. I really hope that you have that you feel inspired, enjoyed the knowledge sharing presentations today. If we didn't answer the questions in the chat, please write us an email on alumni@dfcenter.dk, and we will respond to it by email. For now, we will, at the NIDA Fellowship Center, plan our next Knowledge in Action talk. And please, if you haven't, subscribe to our newsletter, and please follow us on different social media platforms. you are very welcome to join our next Knowledge in Action session as well. Now there's just left to say thank you very much for spending the day with us, and please make sure to follow the next Knowledge in Action thought. Thank you. Bye.